On this week's episode of Plastic Surgery Uncensored, I'm going to be doing my Q&A session with my producer, Maria. You're definitely going to want to tune in, A, because the questions are going to be interesting, and more importantly, maybe your question will be answered. So make sure to tune in to this week's episode of Plastic Surgery Uncensored. Welcome to this week's episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady. This week, we're going to be doing Q&A session with my producer, Maria. We'll be going through the questions that you guys sent in and answering those questions. So hopefully if you hear your question, you'll get the answer you were looking for, and you find this episode to be entertaining and educational. So welcome, Maria.
Hi there, Rady.
All right, so Maria's joining me from Miami.
Yes, which is nice and cold.
Is it cold?
Yes, it is.
Oh, well, then I won't tell you what it's like here. All right, Maria. So let's see what people have written in. As you know, we do Q&As, everybody, every so often. We try to collect some of the questions that you guys send in through the different portals, whether that be through the podcast, whether that be through our Instagram, which, of course, is Dr. Rady, whether it's through Facebook. Anyway, so what's the first question, Maria?
Okay, so the first question comes from Hilda Shuri. What is the best treatment for thin skin and lines on the neck without surgery?
So, Hilda, the question you're asking is about thin lines, thin skin and thin line. Is it thin skin, she said, or just?
Thin skin and lines on the neck.
Right. So that's a great question. It's actually one of those areas that has not a lot of good options, hence why you're asking the question. So, of course, if you have loose skin, excess fat, etc., my suggestion to you will always be doing a neck lift. I don't think there's ever going to be a procedure non-surgically that's ever going to be as powerful as a neck lift. But even if you do a neck lift or a facelift, it's not going to get rid of the thin lines in your neck. So thin lines is a matter or an issue of the skin quality, not about the skin tightness. And so usually you need to do things that address skin quality. So one would be some type of skin resurfacing, perhaps a laser to the neck, maybe a fractionated CO2 to the neck, or another type of laser. You may want to, it's a little challenging, but some people put some very superficial fillers into those wrinkles in the some of the rings that people develop.
But isn't that natural? Like I do it.
Every human
isn't it natural to your neck movement? I mean, it would need.
No, it's
to
not going to inhibit your neck movement, but the reason you get them is because we all have folding, right? Some people, as the person who asked the question inquired, some people have thin skin. And when you have thin skin, the movement over the course of 40, 50, 60 years then leaves wrinkles in your neck, whereas in people with thicker, oily skin, it doesn't. So you want to maybe use a little bit of filler, very difficult to do in the superficial plane. Also, perhaps some kind of skin resurfacing. But by and large, there isn't a really great solution that's non-surgical, at least not in my opinion. And as always, what's that?
Or a turtleneck.
Yes, you look fantastic. Both of us are sort of wearing turtlenecks. Mine, yes. that's an option.
Yes, that's an option. Okay. Pam Sif says, could you talk about piezo rhinoplasty? What's that, an Italian version of it?
Yeah, it is actually Italian. So Pam asked a question about a piezo electric rhinoplasty. I'm not going to give you a whole lecture on it. It's a technology that's like, I believe it's ultrasound energy. Nevertheless, it's a technology has been developed for some years. And the idea is it's a tool that assists you in doing rhinoplasty. For example, it helps break the bones. It allows you to shave off the hump. And the idea, it does so in a way that's less traumatic and less swelling and less blood loss. So that's the theory behind it. I think it's a mixed bag. It's a very complicated technology. I don't think, as someone who does as many rhinoplasties as I do, that it really makes that big of a difference. In other words, I love technologies that really revolutionize the thing that you're doing. So for example, there's a Keller funnel. That's a funnel that we use during breast augmentations. It's a funnel that you put an implant in and then you push the implant through the funnel into the breast. So you don't have to touch the implant or force it through a little hole. In my opinion, that revolutionized breast augmentation. In my opinion, that should be used by every plastic surgeon doing breast aug. Piezo or piezoelectric rhinoplasty is just interesting. It's cool. It's a different way of doing it. I don't think it's revolutionizing rhinoplasty. I don't think it's leading to exceptional results or changing the recovery that much where it's like, oh my God. So I don't see it being adapted anytime soon across the board. And I certainly don't think it's necessary to do a good rhinoplasty.
Okay, so we have Tally Levy or Levi, 67. Breast reductions for teenagers. Yes, outcomes, thanks. Didn't we had an episode?
Yeah, we actually had a whole episode
with the mother with the daughter.
Correct. A breast reduction in a young girl, I think she was 16, with her mom. And the reason we had the episode is because of these kind of questions, which is it's a very, very important subject matter, and it's very common. So people assume a breast reduction is going to happen in an older gal, someone who's had a bunch of kids, maybe someone who's gained weight. But there is something called juvenile hypertrophy, which means that when you develop your breasts at 14, 15, 16, and 17, that you develop such large breasts that it has nothing to do with weight or height. It's just pure genetics. And your breast can be, I don't know, you could be 5'2", 120 pounds and have a G-sized breast. So you can just imagine how that impacts your psychology, your self-confidence, the ability to do exercise, wear clothing, bathing suits, going to the gym, dressing rooms with your friends, buying bottoms and tops that matches, the discomfort in your upper and back and neck. So there's 100 reasons why having very large breasts young is important to address. And absolutely we do them. And in general, breast reductions are very well received. I mean, patients have like a 97% satisfaction rate, but in young women, it's like almost 100% because it liberates them. They can be young and normal and be like everybody else. So it's a really, really happy patient population.
Yeah, and I remember in the case of the episode that we had, which the people can look it up and listen to it, it really was life-altering for that young woman because she was able to do all those different activities like the cheerleading and the running without feeling the stress on her body and the wearing those tight bras. And her mother said she was psychologically very happy because her daughter was happy, you know?
Yeah, it really can.
Happy daughter, happy family.
Yeah, exactly. No, that young lady was, and I've seen her since several times, and she's lost weight because now she's exercising. I mean, there's so many, the ripple effect is incredible. So I am a huge fan. Of course, in a young girl, you need to be mature. I mean, that goes without saying. You're not going to do operating in a very immature young lady, but 16-year-old women are often way more mature than a 16-year-old boy, often. And I think that I've seldom seen anyone that's so immature that we can't operate on them.
From Margaret Might, would you prefer a brow lift on someone in their early 20s?
So would I perform a brow lift in someone in their early 20s? So let's just talk about this. Basically, this is a universal question. It's about doing certain procedures on young people. So there's two reasons to do a procedure on a young person. One, they need it. Two, they want it. So what does that mean? So if you're 20 years old and you were genetically born with excess eyelid skin, let's just make that up, and you come to me at 20, there's no reason why you need to wait till you're 50 to undergo removing the eyelid skin because you're 20 and, oh my God, you shouldn't do that in a 20-year-old. Well, what if you have the same issue a 50-year-old has, but at 20? Does that mean that you should suffer for 30 more years so that you're age appropriate? So if you have an issue, like we just said on a large breast in a 16-year-old, then I fix issues based on how they present, not just because someone is the right or wrong age. So if a 20-year-old comes and their brows are sagging, which is quite uncommon, then I would do it. The second scenario is because they want it. What does that mean? I'm a normal 20-year-old. I have beautiful brows. I look fantastic. But Bella Hadid did a procedure called a ponytail lift, which is a term that was created by a doctor for marketing purposes. And her brows went sky high. And I like that look. that's a whole different ball of wax, because now you're taking somebody who doesn't have an issue per se, and this is a little bit of a slippery slope, and you're doing a procedure on them at 20, like, hey, I want a stronger jawline, I want to get a facelift at 20. Well, really? So it's a matter of each person's decision making, each person being the surgeon. I know that a lot of surgeons will do it because the patient requests it. I have to take it on an individual basis. So this brow lift question comes predominantly from Bella Hadid, because when you look at her transformation at the age of, I think, 18, 19, 20, she suddenly went from having downward brows to upward brows. And of course, she's beautiful, was before, and beautiful afterwards, but it's undeniable that she looks better afterwards. So there's a huge push in younger patients today to do facial surgery. But the interesting thing is we say it's okay when it comes to the nose. You wouldn't, if I said there was an 18-year-old and I did her nose, you wouldn't think twice, would you, Maria?
No.
But if I said to you there was an 18-year-old and I did a brow lift, you'd be like, what? Why the hell would you do that? So we have to ask ourselves that question too, as to why do we psychologically agree to the nose but not the brow? So I don't have a fixed answer. I take it case by case, and it would depend on the person. But I certainly am not going to do a facelift in a 20-year-old because she wants it. Put it that way.
Good for you. Okay. How about how far out in advance can an EKG and blood panel still?
No, we'll skip that one.
No, I got to write these down. Okay, so the next question is tummy tucks and possible getting a keloid after surgery?
So, I mean, the question is, after you do a tummy tuck, what's the likelihood of getting a keloid? So, as you know, when I answer your questions, I try to make them general questions. I don't like to answer specific questions because they only apply to one person. I'm going to make this question is, after you have a surgical procedure, tummy tuck, breast lift, facelift, etc., what's the likelihood of getting a keloid? And the likelihood of it, what is a keloid? How do I get it? How do I avoid it? So first and foremost, 99% of the people who say that they get a keloid or afraid of a keloid do not have a keloid. We had an episode on this. It's called scarring. They have what's called hypertrophic scar. And it's not just me being, oh, such a stickler. They're completely different. A keloid is a phenomenon that generally is genetic. It's a predisposition. And it's like when you pierce your ears, and all of a sudden you have a huge cauliflower growing out of your ear of scar tissue. A keloid is something where the scar grows well beyond the confines of where you've done surgery.
Mm-hmm.
A hypertrophic scar is what I refer to as a crappy or shitty scar. Thick, raised, itchy, dark, all those scars that we look at and like, ugh, that's terrible. Those are 99% of them are hypertrophic scar, which is a medical term for saying a terrible scar. So the question is, how do I avoid getting a terrible scar anywhere? Breast, belly, wherever. So part of it is you. How are you going to heal? Are you genetically predisposed for hypertrophic scars? Are you going to make a thick scar, a brown scar, a raised scar, a wide scar? So some of it is just genetics. Some people make good scars, some people make terrible scars. The other half of it, in my opinion, is all about closure. How are we bringing you together? How are you sealed? How are you closed? How many layers? Who's doing it? What type of suture? How much tension? So why tummy tucks are at risk of getting a thick scar is because many surgeons remove way too much skin. So when they close you, you are tight. Ooh, that sounds good. No, that does not sound good. There's tight, and then there's like drum tight. And when you're drum tight, your skin is being pulled and pulled and pulled. And that body generates a boatload more scar tissue because it's trying to prevent you from pulling apart. So you will make thicker scars because your body needs that scar to keep you together. Well, then it's not your body that's predisposed. Your body's doing what it's supposed to do. Your surgeon is an idiot, and he removed way too much skin. And tummy tucks are notorious for shitty scars because doctors remove way too much skin, and then the scar thickens. That's the same thing with breast lifts. So there is no simple answer, and absolutely it has nothing to do with lasers and creams and scar creams and silicone and vitamin E and steroid inject and all that garbage.
But they do make you take a certain vitamin before you do surgery, right?
Not at all. I make you take 0 vitamins. I never have you do anything. None of that matters.
Okay.
None, 0, zilch, nada. If I do a shitty job or you have really terrible genetics, you're going to make a crappy scar. If I do a great job and you're a regular person, Whether you use creams, lotions, potions, or nothing, you're going to do amazing, period. It's $1 trillion business. Everyone is running out after the fact trying to stick some kind of lotion or cream or something on there because they want to make the scar better. None of this has science. There's no proof any of this crap works. Otherwise, why would one doctor have it and another doctor not? It's not proprietary. We'd all get it.
You know, when I had my C-section 33 years ago today, precisely, I got a scar, a thick scar. And then the second C-section I had is a thin line and it went away.
Right.
So obviously it must be that you were saying.
Right. So it's not you because you didn't change. Did
Right.
you have the same surgeon or a different surgeon?
Different.
I wonder what happened. So the first surgeon will tell you, listen, Maria, I'm so sorry that you made this ugly scar. Your body just tends to make keloids. Then the second surgeon does your surgery and all of a sudden your predisposition for keloids went away? No, he just did a better job of closing you. The first guy did a shitty job of closing you. Staples, glue, whatever, I don't know. So that is perfect proof of what I'm saying. It has to do with the doctor and your genetics.
Well, let's take a quick break and we'll be back with more questions for Dr. Rady.
Welcome back to our episode of Plastic Surgery Uncensored, our Q&A, question and answer session. I'm here with my producer, Maria. So Maria, what you got? What else you have for me?
Okay, let's look it up here. There was one more right here. What is your approach to drains with abdominoplasty?
So do I or don't I use drains during tummy tucks? And so this is one of those things, and I have a whole section on this as well. You know, a lot of what is being done today is science driven, meaning the science says that we should do this and we shouldn't do that. And a lot of what we're doing today is marketing. Marketing says patients want to hear this, patients want to hear that. So anyone who knows me knows that I hate things that are done for marketing reasons. So in my opinion, drainless tummy tucks originated and are being done so for marketing reasons. So what does that mean? When you do a tummy tuck, you lift up the skin, you take the excess off, you fix the muscle, blah, 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 and then you close the abdomen. There's a really large area that's open inside the abdomen for a period of time until it closes. Your body will naturally make fluid. Okay? Then the question then becomes is what do you do about that fluid? Historically, we use drains. Drains are tubes that come out of your body and collect that fluid usually for about a week. And then at the end of the week, you remove the drains. Okay, pretty straightforward, no problem. The problem is the majority of the drains that people use are, in my opinion, cheap drains. How can a drain be cheap? They're drains that they are called hubbed drains. That means a drain is like a noodle. And then the part that enters your body expands to be twice the size of the noodle. So when you go to take that drain out, you got to pull it out and yank it out. So when you do that, it hurts. So when patients go write reviews over the last 25 years about tummy tucks, blah, 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 tummy tuck, oh my God, OMG, the drains. Oh my God, it made me cry. Worst experience ever, right? So then the next series of women who go in, they're like, oh my God, Dr. Bond, do you use drains? Dr. Bond, do you use drains? Because I heard it's painful, right? You understand that now? So the drain that I use is called the Hubless Drain. It's a noodle. It's a noodle from beginning to end, meaning there's no change in size. When I go to remove that noodle, you don't even know I removed it until I tell you it's out. So the fear that's been propagated over years online, patient to patient, is about the drains hurting. The drains otherwise have no issue whatsoever. So doctors hear this thing, well, I would get a tummy tuck, but the drains. And so then all of a sudden you have this concept called drainless tummy tuck. Ooh, that sounds good. You mean you're not going to use a drain? So what you do instead of putting a drain is you put stitches. They're called progressive tension sutures or quilting sutures. And you close the inside of the abdomen with these stitches as you get out. So there's no need for a drain. Okay, that sounds good. Not so. I don't like those drains, those stitches for a number of reasons. Number one, I don't like quilting. It causes the abdomen to stick in certain areas, and I don't think it leads to a smooth abdomen. Two, I think if those areas rip while you move, then you'd get bleeding there. So either way, it doesn't matter. But I want you to understand the idea of where drainless tummy tucks came from and realize that it's more marketing than it is science. As a result, I use drains. As a result, I use hubless drains. And as a result, those drains have zero is a strong word, minimal discomfort upon coming out. So that's my stance on drainless tummy tucks.
Sounds good.
Okay.
Either way, it sounds painful. Either way.
It's doable.
Yeah. Okay. So the next question is, how long after cesarean do you recommend waiting to get a tummy tuck? Well, first of all, I think you'd have to decide if you're going to have more children, right?
Yeah. So that's a great question. So it's got a lot of components. You hit the first one on the head, which is you only go and get a tummy tuck ideally when you're done having kids. Now, you have 3 kids, you're done, you're 28, you're good to go. And then at 37, you're like, oh my God, I decided to have another kid. That's fine because that's how life is. But if you know you're going to have another kid and another kid and another kid, don't have a tummy tuck in between because you're just like, oh, this summer, I want to wear a bathing suit. Don't do that. That's just dumb. Go have your kids, be done with it, and then go get an abdominoplasty because it's a one and done kind of a procedure. You really only want to do it once in your life. It's not like a breast augmentation where you can change the implants, et cetera. Number 2 is if you decide you're done with having kids, you don't want to do it. Everyone's like, can I do it at the same time as my C-section? And the answer is no, you cannot. But I heard a celebrity, I heard J-Lo did it. No, that's a lie. That's one of those urban legends. You cannot get a tummy tuck or a mini tuck or any kind of tuck during a C-section. You got to heal. Why? Because there are women who get a tummy tuck. Listen, when you give birth, you're going to have extra skin. Always. Every woman, every single woman has extra skin. You just gave birth. But the thing is, a lot of women, their skin shrinks back and they're good to go. Well, how do you know which one you're going to be? I just removed half your skin because it was excess at the time of your tummy tuck. You needed that skin. So we don't remove anything until everything, the dust is settled.
And you could get the scarring also if you remove too much, right?
Right. But it's more has to do with you just don't know what to remove. You're in the middle of a dust storm. You know what I mean? So the ideal time to do it after C-section is as follows. Number 1, you want to be more or less around your ideal weight. So let's say you are normally 140, you got to 190. You don't want to do your tummy tuck until you're right around 150 again, which is around your ideal weight. Secondly, you want to have given enough time where you're kind of back and active and you've recovered from the C-section discomfort and immobility, which is usually about 3 months. You also want to be done. You also want to have enough time for your blood levels and all that stuff. You know, giving birth can really impact your blood levels. And so you want to make sure you stabilize your bodies at what we call homeostasis. So I would say realistically, you don't want to go back. You don't want to get a tummy tuck any earlier than 3 to 6 months after having had a C-section.
I would think because my body didn't go back to its shape, like literally 9 months after I gave birth.
Yeah. And that's normal. That is a normal woman takes about 9 months, 12 to 12 months to get back. However, there are women, we all know them because the women know them because they want to stone them. They have a child within like 4 weeks, they're in like their pre-pregnancy genes.
Yeah.
They're unicorns, but they exist. They exist. They just have that genetics.
Yeah. I lost the weight, but I still didn't feel my body was at the form, the shape, the way I was from before. And it took me about 9 months. There's a question here that I've never heard of this lipo. Thoughts on submental lipo and fat grafting to the chin.
So I just kind of keep referring you guys to other podcasts. So, you know, the question is submental lipo, liposuction of the submentum. What's the submentum? That's the mentum is the chin. The submentum is under the chin. So the basically fancy way of saying liposuction of the neck. Oh, okay. And the question is with fat transfer to the chin. So I have people who follow me know that I love chins. I teach to lecture for chins. I teach in Vegas to other physicians, et cetera. So I know a decent amount about chin ogs and things of that nature. So I caution you from getting submental lipo because unless you're the ideal candidate, the area under the neck over time gets loose. Mm-hmm. So I have done neck lifts in 39-year-olds who had liposuction under their neck in their late 20s and had literally a turkey gobbler neck. Now that's uncommon, but it can happen. So what you want to do is you want to be careful when you go out and run out and get liposuction under your neck, whether that's liposuction or cool sculpting or Kybella or any of these machines or devices to get rid of fat. Your best bet for under the neck, unless you're genetically unlucky, is to just lose weight for the neck. Mm-hmm. Now, the second question is, can I put fat in the chin? And it's a terrible idea. The chin is a beautiful chin is one that's really strong and broad and powerful. That is in a woman and a man. That's not just a male feature. There is no beautiful woman in the planet who has a weak chin. So everyone knows my stance on jaws and chins. I love strong jaws and chins in everybody. Every human being needs it. But the chin is a bone. It is a strong bone. So I do not recommend ever trying to enhance your chin using a material, filler or fat. Nobody wants a rubbery chin. They want a strong chin. So chins really, unlike cheeks, filler or fat work great. Chins, not so great. So when I do submental lipo, I usually almost always do a chinog in conjunction because the little bit of loose skin you get can be recruited into the chin. So the combination of a chin augmentation and submental lipo is a very powerful combination together. Independently, I'm not a huge fan, and I usually don't ever recommend injecting anything in your chin other than just putting an implant in and calling it a day. It is bulletproof, it is once in a lifetime, and you never need to change it.
Here's a question from chriscrosby.com. Is there generally any danger in operating on someone who has frequent heart PVCs?
So the question is, if I have PVCs, which is a kind of electrical issue with your heart, is there any danger in getting the procedure done?
Is that like a pacemaker? Is that like a pacemaker? No.
No, a PVC is it's a name of a certain heartbeat that you have.
Oh.
It's actually common. It's benign, meaning it's normal. Some people get it. But the reason why I accepted the question is, bottom line is, if you have any kind of underlying uncertainty, yeah, I have some issues with my lungs. Yeah, I have some issues with my heart. It's not that you can't do the procedure, but you need clearance. So if a patient came to me and said, hey, listen, I'm a young, healthy person. I want to get, I don't know, a mommy makeover. But I have an issue, when I was growing up, I had mitral valve prolapse, which is something that can happen in young people. I say, sure, no problem. Let's do your surgery. Let's get your cardiologist to clear you. I have no issue, and I'm very quick to get the help of other people in clearing you for your surgery. You have asthma? Great. I didn't say I won't operate on you. I just want your doctor who's a pulmonologist to make sure you're optimized. You have PVCs and issues with your heart that are benign? No problem. Great. Let's get your cardiologist on board. Oh, you have, you're bipolar? No problem. Let's get your psychiatrist on board. So a lot of doctors don't want to get other people on board in fear of they're going to deny you, whatever. I don't want to operate on you if you're risky. And nor should you want to be operated on your risky. So I always get clearances for everything because it's just the right thing to do. This is elective. We do not have to operate on you. You have breast cancer, you're going to have surgery no matter what. You want your chinog? Well, we're certainly not going to operate on you if you're at risk. Mm-hmm. So bottom line is that PVCs in and of themselves is not an issue, but I usually just get a cardiac clearance in those patients.
Okie doke. Bulbous nose, rhinoplasty, thick skin.
Bulbous nose,
right?
Thick skin rhinoplasty.
This is from Crop. I can't even pronounce it.
Let me see. Who's it from?
QRUBCOSMALSB.
Yeah, I don't know, but they'll know the question.
Yeah.
So rhinoplasty, as everyone knows, is one of my specialties. I love it to death and I hate it to death. I love and hate it to death because anything that's worthy of doing or marrying is a love-hate relationship. So rhinoplasty, one big, huge part of a successful rhinoplasty is the anatomy you start with. Yes, the surgeon needs to be skilled. Yes, they need to know what they're doing. But if the anatomy that you begin with is unfavorable, then no matter how skilled your surgeon is, you will not have as good an outcome as someone who presents with favorable anatomy. So what is a favorable and unfavorable? Just like as a baseball player, same batter, same skills. One pitch, he's going to clear the park and get it out. Next pitch, he's going to strike out. Same batter, different pitch. So the same is true of rhinoplasty. When someone has thick skin, oily skin, sebaceous skin, skin with tons of pores, most people are looking for a bit more refined nose. Nobody wants a big, fat, huge nose. They want a thin, more refined looking nose, men and women. So when you do a rhinoplasty, the only thing we can alter is the bone and the cartilage. So we lift up the skin, we change the bone, we change the cartilage, we make it look beautiful. And then what do? We put your nose skin back down like carpet over the new structures. And in order for you to see the new structures and be like, wow, oh my God, my nose looks so great, you got to wait at least 12 months for your skin to shrink wrap over the new structure. And then you go, oh my God, look at that. That looks so good. Now, if the skin that's shrink wrapping is thin, you're going to see everything. Wow, that looks so good. My tip is so much more pretty. If the skin that you're shrink wrapping over the new structure is thick and oily and sebaceous, you're not going to see much at all. And you're going to go back and tell your surgeon, you suck. You did a terrible job. I came in here with a bulbous nose and I wanted a tip that was more refined, and it's a little bit better, but not that much. So there is a lot of it has to do with your skin presentation. Now, there are maneuvers that we do as surgeons to make thick-skinned be more cooperative, meaning there are things you can do in thick-skinned people. That's why we say, oh, ethnic rhinoplasty, again, mostly marketing. But those things will never take the place if you have super thick skin. You're at the mercy. And know that the 12 months I just mentioned turns to 24 months. It takes a long time for that skin to shrink wrap. So bulbous or oily, thick-skinned noses are not impossible, but more challenging to operate on.
Okay. And we've gotten to our last question.
Last question.
Thoughts on the internal bra. Now, I'm curious about this.
So
that comes from Claudia A.
Okay, so thoughts on the internal bra. So first and foremost, I have no idea what the hell that is, and nor have I over the last 15 years. Now, I've heard the term internal bra used periodically by patients where they read them from other surgeons on their galleries and their websites. First of all, it's not a medical term. In other words, if you say an anchor mastopexy or an anchor lift, all surgeons across the board will know what that is. An internal bra, yet again, dun, 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 is marketing. It's a bunch of nonsense. What happens is they're leading one to believe that there's a way internally, by wrapping you with some material, by putting stitches somewhere, there's some kind of methodology that you can do to lift the breast internally. Now, the reason why I don't know what you're talking about is every surgeon has their own way of doing something, and then they give it this general term, not a scientific term, but a general marketing term called an internal bra. So the problem is, well, what is it? And the answer is, I don't know. What are they doing? Are they using mesh, so quote unquote, which by the way, nobody does. Are they using stitches? Are they using alloderm? What are they doing? That's number one. So the term is very vague and very broad. Secondly, where's the science? Science? Who cares about science? Well, what do you mean who cares about science? Where's the proof? Where are the studies? How many of them have they done? And the third of all is this method any better than a traditional method? So when we do things, we want to do new things so that we do things better. We don't do new things to do it the same way unless it sounds sexy. And I personally think, until I can be proven otherwise, that the term internal bra is a marketing terminology more than anything else. And so as always, a lot of the questions that people ask on our show is they go somewhere, they read something, someone is pushing some subject or topic or name or procedure, and they're like, God, what is this? And there's a reason why you don't know what it is, because nobody does. All right?
If
nobody has a goddamn clue.
Then it doesn't exist.
No, it exists. It just exists in that doctor's office. Only that doctor knows how, because only that doctor has developed it. Just think about that, people, for a second. If there is a procedure or a treatment or something that only one dude, only one woman, only one surgeon in all of the world does, something is fishy. Okay? Because if they were smart, they would teach the whole world and make millions of dollars. They certainly wouldn't keep it to themselves, doing it only in their little offices by themselves. If I found the cure for stretch marks, I promise you, I would not be doing it in my office only for you. I would get on QVC and sell it for $1 trillion, and I'd be in the Bahamas. So if something sounds too good to be true and no one else knows about it, it is too good to be true. It's just the truth.
Right.
All right, Maria. That's all I got.
Thank you, Rady. Another interesting episode. And if people have more questions, they can look at the library of episodes, and I'm sure that there'll be a topic that they are curious about.
Right. So keep your questions coming. We try to do a Q&A every couple of weeks. Send them in. We're constantly looking at them. Make sure to tune in next week. And I'm not even sure what we're doing, but I'm sure it's going to be awesome. And last but not least, download, share this podcast, and share us your comments, and check out our other episodes. All right, guys, until next week, this is your host, Dr. Rady Rahman, on another episode of Plastic Surgery Uncensored.